So hi everyone, welcome to Q&A with a infectious disease researcher. We've got John Tulloch here with us today. John is a research fellow at the Uni of Liverpool. He's worked with and for Public Health England in the past on some Lyme disease research studies that have been published that you may have seen about in the media. And he's agreed to do a Q&A with us for Lyme Awareness Month, which we're really grateful for. So thank you, John. If you want to tell us maybe a little bit about you, your background, and why you're particularly interested in Lyme and infectious diseases, and then we'll go on to the questions that we got.
Brilliant. Thank you, Rosie, and hello, everyone. Thanks for inviting me along and hopefully be able to answer some of your questions here this afternoon. So my background's actually as a vet. I've always been interested in infectious diseases, right through from my original vet degree through to now. And I kind of ended up studying Lyme disease by accident. I've always been interested in zoonotic diseases, so diseases that can infect both humans and animals. And so I was looking to get into an area of research where there was a disease like that, and this opportunity came up to study Lyme disease. And I, to be honest, didn't know a huge amount much about it, and then very quickly got immersed in the world of Lyme disease. So my research has primarily focused on looking at a variety of different health data sets to try and understand the demographics, so the type of people that have been infected with Lyme disease, where that occurs in the UK, and now looking also as well at how they've been managed, whether that be in primary care or hospital settings. So mainly looking at the epidemiology of Lyme disease.
Okay, great. So we put a call out for questions, as I say, during Lyme Awareness Month. The kind of main mission of Caudwell LymeCo is to fund research into Lyme disease. So we wanted to kind of put out the call for questions so we can learn a bit more about the current state of research in the UK and what the future might look like, and what you'll be able to share from what you found out already. We got some great questions back, and we're going to answer as many of those as possible based on your kind of knowledge and experience. So without further ado, we will head to the first question. So we had one here about if it would be possible for you to explain the possible reasons for the difference between the number of estimated case numbers in the study that you published. So you published a study, I think it came out last month, didn't it? That had been in the making for a while, versus the study that came out in, I think it was the end of July last year, by Dr. Cairns, on kind of annual cases of Lyme disease. There was a bit of a difference in numbers. I think based on her estimates, that they're expecting perhaps around 8,000, 9,000 cases in 2019. Whereas I think the case study that you looked at kind of suggested a lower number. So I just wondered if you could briefly take us through, what the differences were in the study that perhaps might have contributed to that.
Yeah, sure. So both the studies that were trying to describe the incidence of Lyme disease in primary care. So the number of people that went to see their GPs for it. And to try and do that, both of us used GP data sets effectively, that they describe about 7 to 8% of the UK population, and they go back to about 98. So they're really large data sets. From these, we need to try and define who has had a case of Lyme disease. Now, with it, it's not a matter of sort of requesting all of the clinical records for certain people. You just get a mass of numbers and letters on
Probably
a big.
Is a bit of a mess as well.
Yeah, on a big screen, and you've got to try and interpret them. So effectively, there's 3 ways of trying to do it. So firstly, there's using read codes. So read codes are for every disease and condition, from Lyme disease to say a broken bone or just a scratch, there's a set of alphanumeric codes that defines that. So that's the best way really of trying to find a Lyme disease patient within the records. The second way of doing it is trying to look at lab tests and results, which also they're coded in that way. And then finally, it's using to try and get the free text of the clinical records itself. So the Cairns paper used all three of these. And so they have the opportunity to potentially find Lyme patients three different ways. When we designed our study, we kept the read codes. As for this type of research, the read codes are the gold standard of trying to identify cases. With the lab tests and results, we decided to exclude them. And the reason for this is because a lot of the time it will just say Lyme test. We don't know what that test is. We don't know. It could be for example, a screening test, or it could be a confirmatory test. It could be an ELISA. It could be something else. So without knowing precisely what that test is or what the test result is, it's very difficult to know whether we can trust that interpretation. And lots of research done in other diseases has shown that with lab test results and GP records, they're often kept on paper and never actually transferred onto the electronic record system. So it's stored as a PDF rather than placed there properly. So we felt we couldn't robustly find all the cases that would have been tested that manner. So we excluded it. And then with the free text, when we went forward for ethics, the free text was no longer available to us. And this was trying to maintain patient anonymity. So
the Cairns had access to free text where doctors might have put Lyme disease in the description.
Exactly.
But and hopefully you would think would have used the same read code, but perhaps not necessarily.
Yeah, or
right.
they may have written something like, "We've seen a bullseye rash. I think it's Lyme disease," and then they may have coded that individual as a rash rather than Lyme disease, and they picked it up that way. And that's the only reason why we couldn't do that was purely, protecting patient anonymity. That's no longer allowed to do it like that. So because we effectively were only able to use one way of identifying patients, and the Cairns paper could use three ways of identifying patients, they were always going to find a few more.
And I think you did acknowledge that in the study as well. You did say that it's likely to be an underrepresentation of perhaps the full amount of cases because of the data that was there, that was available to you. Like you said, that you were only looking at one, just diagnosed in primary care and nowhere else.
Exactly. Yeah.
Okay, great. Hopefully that clears that up for some people. And within the study that you did as well, the second question that was in here was about, do you think that the increase and eventual overtaking in the use of suspected Lyme disease codes could suggest a lack in confidence from GPs in diagnosing Lyme disease? So to give a bit of background to that question, in the study you explain about the fact that there used to be codes up to a certain point, was it 2014 or something, that were either Lyme disease or erythema migrans, and then in around 2014 they introduced suspected Lyme disease or suspected erythema migrans, and you reported in the study that by kind of 2016 the suspected codes kind of were overtaken in use from the common code. So I guess the question there is, is that an indication of GPs still not being massively confident in diagnosing it in primary care?
It's really difficult to know, to be honest. I suspect that that's definitely one of the reasons that people I just have that lack of confidence. But ideally, we need to understand why a GP would use, say, a suspected code, so saying suspected Lyme disease rather than just Lyme disease, and whether there are things like regional differences. So it could be that, say, in the south and southwest, where we know that there's more Lyme disease cases, the GPs in those areas are a lot more confident at putting Lyme disease, where somewhere like Lincolnshire, which doesn't have that many reported cases, they may not be as confident. So I think without actually watching consultations in real time and doing some qualitative research and like interviewing as many GPs as we can, it's quite difficult to understand why they may be doing it. We have interviewed some GPs, and definitely lack of confidence was one of the reasons that came out of it. These were GPs in the Northwest, and a lot had never seen that, they weren't aware of ever seeing a case of Lyme disease before. So what they may do is they put suspect Lyme disease first, and then send blood samples off, and then if that individual has confirmatory blood sample, positive lab result, then they may change the code to Lyme disease. And yeah, I can't really sadly talk about that research more at the moment, but that will be out later in the summer, and so hopefully that will go into a bit more.
That would be really interesting to read, I think, for a lot of people, about, because, you know, like you said, there's obviously a suspicion there that doctors are, like you say, kind of lack the confidence or the experience of Lyme disease. But it'd be interesting to hear it from the horse's mouth, as it were. So yeah, we look forward to that one. There's a question here about how research shows that there seems to have been quite a sharp increase in cases noted between 2013 and 2016 of Lyme disease, and what your thoughts on that, why that might be.
So yeah, Lyme disease is definitely increasing. So like during that time period, so I've pulled out some of just the lab report data from PHE at the moment. So from 2013, it's around about 1,000 cases reported in England and Wales a year.
Lab confirmed, yeah.
Lab confirmed, yeah. And in 2017, it was around about 1,500 cases. So in a 4-year period, it's gone up 500 cases a year, as it were. It's difficult to know at the moment where that increase of cases is coming from. Is it because there's more awareness? So more people, more GPs, more nurses, more healthcare workers are thinking, and the general public are thinking, I've got this rash, I've heard about it in the news, I've seen it on social media, I think I may have Lyme disease, let's go and get tested, let's be more proactive. That could be one element, but it could also be that there's genuinely more cases and more people are getting infected. And again, none of the research that's out there really can disentangle that at the moment. What we really need to be able to do is to identify people almost as they're coming through the GP's doors, or as they're going to like minor injury units or things like that, and try and understand why they've come there, what their history is at that point. All I can see with sort of the type of research I do is how it's written in the records. So there's that period of time that's missing between someone feeling ill and understanding that process that they've gone to until they see the GP. Certainly the climate at the moment, that we're seeing ticks in more northerly parts of the country, and the question is really, as there's more ticks about, are more ticks carrying the Borrelia pathogens? And again, like research is needed to sort of try and explore that as well.
So again, potentially a group of reasons all kind of feeding into that. I know that our founder John Caudwell, he kind of came out and did quite a lot of press about Lyme disease in 2015, and then you had people like Matt Dawson, the rugby player, coming out in 2017. And I know even from the time just that I've been at the charity, which was November 2018 onwards, I've had quite a few people contact me to say, I only really knew because I heard John Caudwell on This Morning, just explaining his symptoms, and that made me think, and I've probably heard that from about 10 people. Just I mean, obviously that's not a massive number, but I think certainly kind of high profile people speaking about it in media. There was Martin McCutcheon was in Hello magazine or something earlier this week speaking about it. So I think there's often an increase, and even Justin Bieber coming out last year, was it? We did get an increase in inquiries to the charity even after he kind of came out and said about Lyme disease, because I think it does just kind of reach an audience that you perhaps wouldn't get otherwise. So maybe incidences like that have contributed to people thinking, oh, that's what my symptoms might be, whether they're kind of early stage or late stage.
There's definitely a lot of awareness, I think, in the media now, and I think I know this is a question coming up, but in terms of like media coverage of scientific papers, as we've all seen, like over the last few months, like the COVID stories are getting, like coming out of research, are getting into the newspapers and websites and things really, really frequently. Other than COVID, there's only, like prior to COVID, sorry, there's only been a few diseases that really get really high profile mentions in the media, and Lyme disease is actually one of them. If you look at diseases that have a similar level of like incidence in the UK, Lyme disease is definitely a lot more high profile. So an example, let me think of an example. So something like salmonella, there's a lot more cases of salmonella each year than Lyme disease, but certainly there's more Lyme disease mentioned in the media than there is salmonella. And like, when I teach students at the university and, give them a bit of background about myself, there's invariably students in the lecture theatre that will come up afterwards and be like, oh, I had Lyme disease, or someone in my family had Lyme disease. So there's definitely, I think, a lot more awareness about it than even 2 or 3 years ago. And I think that's a really good thing.
Yeah, agreed. You mentioned obviously COVID-19 there. One of the next questions we had was about what impact do you think COVID-19 will have on any planned or future research around Lyme disease? And it's a concern of the charities as well, really. What are your thoughts on that?
I think it will slow things down. I think there's sadly no way around that at the moment. So the fact that like this interview is one way of saying it, of we're socially distanced, we're doing this over Zoom. A lot of science, you need to be in a lab, you need to be with a group of people to be able to do that research. So just the social distancing measures in itself makes it a challenge to do a lot of research. So things like recruiting individuals to trials and studies is really challenging at the moment. In terms of the way that the research community and universities are thinking about things at the moment, it's very much COVID-19 is the number one priority. The world has never seen anything like this in our living memories anyway, and the response from the research community is that if anyone has any skills that can be utilized to get on top of things and to try and help us come out the other side of COVID-19 okay, then we should be utilizing those skills. So for example, I've been doing, alongside Lyme research, I've been doing COVID-19 work as well, to try and help out as best we can. So it does mean that a lot of, say, lab space that's been used for a whole bunch of different diseases, not just Lyme, will have now been converted into COVID labs. And until we sort of start answering key questions about COVID, the sort of research won't go back to its sort of normal track. So I'd say it's not, I think things have just basically been delayed, that people want to carry on their research, their research that they're enthused about and that they're interested in. Just like the rest of society, we've just had to put it on hold a little bit whilst we focus on getting on top of COVID. And once we've done that, then everyone is going to want to continue to go back with probably even more vigor than they had before, because they will have missed the research that they've been doing for the, you know, for the last few months. They've been doing something else. Now they want to get back to it.
But do you think that's, you know, not going to happen at all until there is a vaccine, which obviously, you know, could be a long time, or might it be before?
I think it will be before that, and I think a lot of it is going to depend upon how quickly things like lockdown fully ends. Because, you know, I'm lucky in terms of that a lot of my research is computer based, so I can work remotely to a certain extent. But a lot of the people that I work with or collaborate with, some of them are medics, so they've gone back to clinics and back to, you know, really doing frontline healthcare work. Others who are more lab based, they've basically been doing just COVID. So it's certain individuals are going to be able to start cracking on with research in other areas a bit sooner than others, but the sort of research community is still going to be slowed down a little bit.
I think people, you know, understand the kind of dangerous and immediate nature of COVID, and why so many resources have to be, you know, focused on it at this time. I think it just, you know, that also doesn't change the experience that people are living with every day, and obviously the thought of having to wait longer, even though obviously we're in kind of unprecedented times, as is the word of, you know, the term that's being used. I think it, you know, it can still be quite difficult, but hopefully that time moves quicker than usual, you know, obviously, or you know, as quick as possible. Obviously there's charities like Caudwell, LymeCo that have been set up to kind of fund research privately if needs be, but I guess there are also concerns around, you know, what little research money was given to Lyme disease might have, again, understandably, perhaps been needed to have been channeled towards COVID-19, and what, you know, whether that's going to, you know, impact the amount of research that will be taking place once things do get back to normal.
Yeah, and I think some of that is going to be on the funding bodies themselves. So the people that, you know, as academics, we look to certain organisations to get money for grants to be able to do research, and I would like to think that, you know, in a few months' time, once, you know, things are a bit better on top of COVID, we'll be able to start asking for grants again and be able to get money from them. I think, you know, there's so many diseases across the world, so not just Lyme disease, that really need a lot of research. And those research bodies, I don't think, are going to suddenly overnight say, no, we're going to stop all this funding. We're only going to do it in one disease. You know, COVID is horrendous. And so, you know, I know that Lyme disease is horrendous for a lot of people as well. And hopefully COVID is going to be something that we can get up in top of, in, relatively speaking, a short period of time. And then we can return to normal and go on to our other things and go on to our sort of main research priorities. And, you know, we just hope that the research funding organizations have that attitude. From the ones that I've spoken to, they seem to feel that way, that they want to carry on funding things how they were previously.
Okay, that's positive. That's positive to know, fingers crossed. Next question was around, why isn't Lyme disease notifiable? So I don't know if you want to explain maybe what the term notifiable means and just why you understand it not to be.
Yeah. So a notifiable disease is, we've got a list of diseases in the UK that if someone identifies that disease in any setting, it needs to be notified to the government in some way. Once that notification has occurred, and this is the critical bit, there is going to be some form of action off the back of it. So it's going to initiate some sort of urgent public health or disease control response. And those responses could be things like vaccinations, quarantines, or food withdrawal, things like that. So any of the diseases that are on that sort of notifiable list will have an immediate action that will occur if a case is notified. So when we think of Lyme disease as a potential notifiable disease, one of the first things that we need to think about is, what is that action? What is that immediate action that can occur to control the disease and control the disease spread? And that's the difficult bit for Lyme disease. So say I've got Lyme disease and I've got a lab result come back, said, you know, John, you've confirmed with Lyme disease. What control can we do to stop it now? If I don't know where the tick was, what tick population do we try and get under control? What warning signs can we put out? How can we limit that spread?
Yeah, it's not as easy to identify the kind of you know, it's not something that's passed like person to person where you can, you know, that kind of disease, well, you know, that we know of.
Yeah, and I think that's the thing, is that a lot of the notifiable diseases are diseases that do have that direct human to human spread, and so actually there is something that can occur straight away to try and limit the spread and limit the number of people that are infected. I know that speaking to Lyme sufferers in the past at various different events, one of the things that has come up about notifications is, would it actually improve reporting?
Yeah, I think that's probably why they've asked that question. Yeah,
and one of the things is that an example of something that's notifiable is food poisoning. So if you have food poisoning, in theory, that should be reported and investigated. If it is reported properly, then there will be an immediate action. The premises say that that food outbreak, the food poisoning outbreak started from, that will be potentially investigated, shut down. If it's from a supermarket, food would be withdrawn. But what we know from other research is that if, say, you go to your GP and you've unfortunately got vomiting and diarrhea from eating something dodgy, the GP may not report it, or they may go and take a sample, like a stool sample, and send that off, and they'll wait for that lab result to come back, and then dependent upon that lab result, they will then maybe notify or do something else. So actually, less than half of the cases of food poisoning are actually reported, even though it's notifiable. So I suspect that if Lyme were to be made notifiable, a GP would potentially see an individual who's presenting with classic symptoms, but some may notify at that point, but others may actually go and do diagnostic workup first and wait for a lab result before they notify it. So there's two things there of, does it improve reporting? It probably won't. And then actually, what is the
control,
the action that's going to occur if you identify someone with Lyme?
Okay, thank you. Next question was, you had a study on using Twitter to map against where Lyme disease cases are, and how might social media be used to this effect?
Yeah, so in this bit of research, we looked in the UK and Republic of Ireland to see where people were when they were tweeting about Lyme disease, and to see whether it matched up where the cases were. And we weren't we didn't know what we were going to find, to be honest. We just went in totally blind, not knowing whether it would match up, and it amazingly matched up very well. And there were very few exceptions of where there was a high number of tweets and no cases, or a high number of cases and no tweets. On the whole, if you looked at the map of tweets, it looks like the map of Lyme disease cases. And the way that I would see that potentially being used is almost as an awareness measure. So it gives you the voice and awareness of people concerned about Lyme disease potentially. So it has the potential that if, say, there's an area of the country that has a low number of cases, and then suddenly we see there's lots of Twitter activity about Lyme disease in that area, that could signal that actually, why is there concern in that area? Is there suddenly that there's new cases? And it could signal that it's worth investigating in that area. Is there actually cases of Lyme disease? So I think hypothetically it's got some use. I think there's barriers of that being used as a routine surveillance thing. Twitter don't really like Twitter being used
for that kind of purpose.
Yeah, so they don't mind you doing like research on Twitter, but they don't really like it being used as a continuing surveillance system without sort of contracts and things set up. And to be honest, this study was the first time this type of work had been done before. So actually, we need to ideally look at it with other diseases as well and see how well it works, and see whether we can look at more local geographies and try and understand a bit more about why the maps matched so closely, as it were.
I suppose as well, it might also help to inform like where kind of public health awareness campaigns could be directed, maybe, like you say, if there's a particular growth in cases in one area, or people talking about it, depending on the reasons for that, maybe that's something to consider. So yeah, it's definitely an interesting way of using social media. And the next question, so the paper which dealt with who was most likely to contract Lyme disease, so one that was looking at demographics, showed that men were more likely to get it with peaks in childhood and late middle age. Why was there no attempt to correct the press saying that it was older white women who were most at risk? So I think this, just as a bit of background, I think this refers to a study that came out towards the end of summer. Was picked up in the media, and the headlines were all about older white rich women more at risk of Lyme disease. But when you actually delve into the stats, it actually seemed to suggest that it was men, and like I said, that there were peaks in childhood and late middle age. So I think whoever it was that asked that question, wondered why there wasn't any correction made, to the possibly erroneous, view that the media had given to that study.
Yeah. So I think one of the issues around this was that there were two of our papers that were published within about 2 weeks of each other.
Right.
So I think some people had read one paper, and if they'd read one paper, it gave slightly different outcomes to if they'd read that other paper. So we've effectively done 3 bits of work that look at the same thing in 3 different health data sets. So we've looked at lab confirmed cases, hospital cases, and primary care cases. So all the media attention in the summer was about the paper on hospital cases. If we look specifically at the age and sex element of each of those papers, all of them show peaks in childhood and late middle age. They show that as consistent for both sexes. For both sexes, we see that trend, and that's common through virtually all the Lyme literature across Europe. When we then look at the sex differences in lab data, we see more men.
Mm-hmm.
In hospital data, we see more women. And in primary care data, there's not really a difference between the two.
Right.
And most likely that's to do with differences in health seeking behavior rather than to do with the disease itself. So when we, with the journal that released our paper, they wanted to do a press statement. So we created the press statement, which said in this paper, the age group and the sex that had more were women, and they were either children or late middle-aged. However, we believe this is due to health-seeking behaviour because of X, Y, and Z and other literature. That all went out in the press statement. What media decides to pick up from the press statement is very different. Most of the main news agencies and broadsheets spoke to us, and we clarified points to them. But it is what they
decide to put.
What they decide to put.
So you put it out as a press statement, and there were points that you did clarify, but essentially what the media, even if you were to give them a correction, the media is still going to print.
I think it was less, I think the issue was less that it wasn't necessarily a correction was needed. It was more that this is what was seen in this study in hospital cases.
Yeah.
And that in different settings, we would see something slightly differently. And it was that second half that was removed each time.
So it wasn't necessarily wrong what was reported or found in the study. It was just this, it didn't really give
subtlety.
the context. Yeah, the subtleties. Yeah, sure. Okay. And I think that the next question kind of really feeds into that, and you probably kind of slightly answered it, but they mentioned about the paper that dealt with hospital admissions, indicated more late middle-aged white women, as you mentioned. Given that more men seem to contract Lyme, there was little effort to work out why these women, probably not given to wasting NHS time, access secondary care directly. So as you said, more men were diagnosed by lab confirmed cases, so blood tests taken at their GP perhaps, but more women were being admitted to hospital. And it was mentioned here that some patient experience suggests that women are commonly thought by doctors to be making up their symptoms as a result of being menopausal, and therefore they have to access A&E in an effort to get symptoms taken more seriously. Said, why do you think that this was? That basically, I think they said, why do you think more women are being diagnosed in hospital than in primary care, as in GP?
I think it is really difficult to understand this one, and from the data sets that we've got, there's no way that we can sort of find this out. We really do need to go out there and to get qualitative researchers, which I'm not really one, but a qualitative researcher to go out and interview properly both men and women's patient experiences, and understanding their movement through the NHS and through private healthcare as well, and not just people that have had more complex cases, but also those that have just almost read their textbook case definition of a rash, how they've been looked after. I would argue that overall there is no sex difference of who gets Lyme disease. I think the fact that in primary care that we don't see a difference in sexes there, I think that's going to be most people's first port of call, is to go and see their GP. So I think what we're seeing in both the lab and the hospital is an artifact of health-seeking behaviour. So is it, for example, that men are more reluctant to go and see a doctor, more reluctant to potentially go and seek medical treatment, so see their doctor at a later stage of illness, and so that means they're much more likely to get a lab test done, where women may be more likely to go at an earlier stage of illness, where if a rash is seen, they may just have been treated without any lab diagnostics.
Mm-hmm.
It is difficult to know. I think that there is research out there that shows that women are much more likely to access and seek healthcare more than men. But without doing that sort of, I suppose, that patient experience research, it is difficult to
Mm-hmm.
get to that understanding of that. And alongside that, you would need the healthcare interviews as well, so you can see what's going through, say, doctors in A&E, doctors in infectious diseases who would be managing the cases of Lyme disease.
Okay, thank you. Next question was, what percentage of ticks carry Borrelia? Are you testing ticks in parks and gardens in the UK in order to inform the public and Public Health England?
So the percentage of ticks that carry Borrelia ranges quite a lot between the different studies that have been done. So anywhere from between 2% to around about 18% carrying it. Ticks are really difficult to do research on, in terms of they stick to their little habitat really well. So you need to be able to identify that habitat, and ticks don't move a huge amount away from that habitat unless they're being carried by birds or something like that. So a lot of the research is on very localized tick populations. So whether that be around a few woodlands in a certain county, or in ticks in a city park or something like that, for example. The largest study that I could find was a Scottish one, and they've surveyed well over 2,000 ticks, and around about 5.5% of them were positive with Lyme causing Borrelia. But it is going to vary quite a lot. So it's, if you're bitten by a tick, you don't necessarily know whether that tick is going to have Borrelia or not. So the important thing is just to remove it in the appropriate way, as though it had Borrelia.
Yeah.
In terms of testing ticks myself, so I'm not doing that as part of my research. I'll leave that to the entomologists.
I know Public Health England, they were doing a tick testing thing at one point. I'm sure they were encouraging, the public to kind of send in ticks for testing. I'm not sure.
Yeah, so they've got a scheme called the Tick Surveillance Scheme. That basically, if you Google that, you'll be able to find that on the government website. And that basically, any tick that gets sent in, they will speciate that tick, and then they're holding all of those ticks in a freezer at the moment. And I think there are plans ahead to test all of them, but I'm not sure when.
And the details.
I don't know the details on that.
But it exists. It is a
thing.
It
exists.
And are you aware of any other plans? I mean, I appreciate it's not kind of tick ecology isn't your area of expertise, but so they mentioned about testing ticks in parks and gardens. I know obviously Richmond Park has been known to be a bit of a hotspot or thought to be a hotspot for Lyme. Have you heard anything on the grapevine about?
There are lots of different tick research groups across the country. I would say that there's probably more researchers working on ticks than there are Lyme disease itself.
That seems to be the case, certainly in the research workshop that we were at last year in November. There's definitely been a big focus on tick ecology, which obviously does have its place, but it doesn't really change the patient experience. So
no, and there is definitely a lot of research going on. I think one of the main research areas at the moment is on Uist, so one of the Scottish Isles, where they've had an awful lot of Lyme disease cases, and because it's an island, they have the ability to almost explore the whole island as an experimental unit. So I know that there's a lot of work being done there, but yeah, there are quite a lot of tick groups across the UK, and I know that also there's commercial groups that do tick work. So I'm sure that lots of your supporters have heard of the Big Tick Project,
Mm-hmm.
and they obviously have collected ticks off pets and looked at Borrelia in them as well, and they find similar percentages of ticks carrying Borrelia on the pets as they do out in the wild, as it were.
Okay, fab. Hopefully, as I say, a bit more, but I think, like you say, that there has been quite a lot in tick ecology, and like I say, I do think it's important, but I definitely think, you know, that the feeling for the large amount of patients is focusing research now on kind of testing and diagnosis and treatment, that kind of thing. And then last question that we've got for today: do you think Lyme disease is rare in the UK? I don't know if that's a bit of a trick question.
No, I thought this was the hardest question of the lot, and I had to do a little bit of looking into this one, because how do you define rare? And I actually found that there's a definition.
Okay.
So the European Commission defines a disease or condition as rare if it affects fewer than 1 in 2,000 people.
Right.
If you do the rough maths of Lyme disease, it's in the UK, it's around about 1 in 20,000 people. So according to that definition,
to those terms,
Lyme disease
is more rare. I think the question, you know, that's asked is, whilst it's in terms of, do you think Lyme disease is rare in the UK? I guess, well, my personal interpretation of that question is they're wondering, do you think it's as rare as people think it is? Do you know what I mean?
I think
that has been
does.
thought in the past, you know, would you class it as a rare disease, or would you actually, even outside of those specific terms that are given, I think that's probably where it's trying to lead.
Yeah, I think in terms of, I believe all GPs should be aware of Lyme disease and should know what it is. So on just those terms alone, then it means that it's probably more common than people think it is.
Sure.
We've definitely seen, as we've discussed already, we've definitely seen an increase in it, and all of the work that we've done has shown that there's been a year-on-year increase in Lyme disease,
and more cases than, you know, those that are kind of officially named by PHE as well, you know, which obviously is based in lab confirmed.
And yeah, and there is, and it is one of the difficulties with Lyme disease is that, you know, there are some people that are going under the radar, as it were. But, you know, from personal experience, as we were talking about earlier, we know of people that are total strangers that you tell them what you're researching or working with, and they're like, oh, I know someone who's had Lyme disease, or I've had Lyme disease myself. So I think it is probably more common than, you know, people believe it is. But by this definition of the EU Commission, it's technically a rare disease, but 1 in 2,000 means that a lot of diseases are rare diseases.
Well, yeah, definitely. And of course, it doesn't negate the impact of those that are experiencing it, whether it's classed as rare or not.
No, and I think that's the fundamental point, isn't it? Is that it doesn't matter how common or rare a disease is, it is how it impacts an individual and their family and their friends, and that's the important thing. So if it's having a serious impact on people's lives, then it's an important disease.
Lovely. Well, thank you so much for taking the time to answer our questions today, John. Like I say, I know you're really busy at the moment with all your work with COVID-19, and I think the Lyme disease community do really appreciate, you know, scientists and people in the medical profession just being open and giving their kind of time and knowledge and thoughts and expertise, because it's always good to kind of hear it direct from the mouth. And thank you for all the work that you're doing in Lyme disease and trying to get those answers for people. We really appreciate it.
Well, thank you very much for giving me the opportunity to chat to all your supporters, and thanks for doing all the good work that Caudwell Lyme are doing.
Thank you.